Good morning. Thank you for being with us. This is Khalil Hachem with US Arab Radio. First, I would like to wish you a happy and safe holidays. Hope that you're having a great time with family and friends. May the Lord bless you with a great year filled with happiness and good health. Today is Tuesday, December 17th, 2019. Welcome to another segment of Doctor Behind the Microphone. With us today is Dr. Shamma, a founding member of IVF Michigan Fertility Center and one of the leading reproductive infertility specialists in Michigan, Ohio, and the Middle East. Good morning, Dr. Shamma. Happy holidays to you and your family.
Well, happy holidays to you, to all our listeners in Michigan and in Ohio or wherever they're listening to us.
All over the world.
All over the world.
Wonderful. How do you spend your holidays?
I usually spend it mostly with family. With 6 kids, it's hard not to spend it with the family. So even if I have to pick and choose, it's
Absolutely.
Always with family members. And that's what I like to do.
Do you normally travel?
We normally travel, and a lot of times we travel overseas to the Middle East, to Lebanon in particular, but because of the current situation over there, it's not going to be possible this year. But we're traveling overseas.
Unfortunately, Unfortunately, it's not going to be possible. You know, as I mentioned to you, that again, I was planning to travel myself, and considering the situation in Lebanon, we pray for everybody there. Any particular activities during the holidays? I know you spend it with kids, other than shopping and.
I try to minimize shopping if we can. It's mostly giving. That's basically to either our family and our friends and the community. We do skiing. When we go oftentimes to areas that are warm, we do swimming.
Swimming, that's correct.
Yeah, because we'd like to see some sun. Currently in Michigan, we don't have too much of that. Yeah.
This is why we take vitamin D, huh?
Yeah, we constantly.
Yeah. I take it every day, and this is something that we have to do. I normally like to cook over the holidays. There's some time in there, and any cooking you do at home.
In our family, we sort of divide labor.
Okay.
Different labor-related activities are done by certain people, and others do other things. I do not do too much cooking, but I enjoy eating.
Okay. What's your favorite dish?
Well, mostly Lebanese food. So all of them, any of them.
Any of them. Okay. Last time you mentioned to me you don't eat kibbeh.
No, I don't eat raw
kibbeh.
Yeah, but I love kibbeh in general. Yes.
Yeah. And I remember saying, and somebody asked me to ask you that again, the difference in meat on fertility. Certain meat is more detrimental than others.
Meat as a general concept is not detrimental to fertility, except that if you do raw meat, and especially for women, it can be associated with certain parasitic infections and or bacteria that can potentially affect the developing pregnancy and therefore the baby. So that's on one end. The other thing has to do with fish. The consumption of fish has to be curtailed to pregnancy, in the sense that mercury in the fish affects pregnancy and affects the developing fetus, and therefore we try to minimize fish that have high content of mercury in them during pregnancy, but at the same time recognizing that we advise women to eat some fish during the week.
Is there any particular kind of fish that...
Any big fish usually has more mercury in it. For instance, shark, tuna, so on, because they're bigger in size, usually have more time to concentrate the mercury in them, and therefore the smaller fish, the better in general.
Yeah. Now, how does it affect the fetus if they eat a lot of fish? The mercury, what does it do?
Mercury is detrimental not just for the developing fetus to any significant degree, but it's also detrimental to us humans if we're exposed to mercury, quite a bit of it, even as adults. And it's also for kids. So it develops the fetus because it's a heavy metal. It screws up a lot of the metabolic processes in the bodies, and as a result of that, you can have a higher rate of concerns related to those babies born because of that.
Absolutely. We're getting to the end of the year, and it sounds like it's been a busy year for you.
Yeah.
What kind of a year? How busy has it been?
Well, I'm busy because we tailor to a population that is at risk, in the sense that in the state of Michigan and Ohio, there is almost 12 to 15% of the population has issues related to fertility. And We're the largest center in Michigan and Ohio that offers services related in that field. And to that extent, we see a lot of patients with concerns and issues
Is that a large
fertility
number?
issues.
Is that a large number?
It's in terms of the population, just do the math. I mean, in the United States, just to put it prospectively, nationally, there's around 7.5 million people that suffer from infertility. So it's people need to realize that it's not them. 1 in every 10 couples will have a problem conceiving children. Same thing exists in Michigan, same thing exists in Ohio, same thing exists in most of the other parts of the world. So that is something that affects a lot of people. The problem a lot of times is the access to medical care in this field is sometimes limited because of multiple issues, because of financial issues, social issues, stigma-related issues, and so on. And certainly, we try our best to offer the services to as many patients as possible to help as many people as possible at the end of the day.
How much the psychological aspect, people have to come to terms that I need to go see a doctor?
Well, I mean, there have been studies that looked at that. There is a lady from Harvard, Alice Domar, that have found out, have done research to equate the stress related to infertility equivalent to the stress when somebody is diagnosed with cancer, for instance, in terms of the amount of stress that puts on the person herself or himself, on the relationship between the husband and the wife or the partners, in terms of the family dynamics to the immediate family and the extended family. All of them are affected. And there is unquestionable evidence that stress affects ovulatory pattern in women, and to some degree even affects the success of various procedures or technologies that we offer in those situations. So we try, when we see patients from a medical perspective, to be aware that the emotional component to it is so significant and offer so many services to help ameliorate those concerns.
Over the year and this past year, what kind of advances or differences in the way you do and you deal with patients?
The main advances have to do with genetics. Mm-hmm. And let me put this in perspective. In the past, when people do in vitro fertilization or assisted reproduction, or what you used to call test tube babies — there are no test tubes, by the way.
Sure.
They used to put multiple embryos.
So what do they call it, test tubes?
I have no idea why they call it test tubes.
Because I thought there was a tube.
There's no tube, they're dishes.
Okay.
So they should have called it a dish baby.
Dish baby.
Yeah. And maybe not to confuse it with the satellite TV thing. But anyway, so in the past, people used to put multiple embryos to achieve a particular result, and therefore pregnancy, and therefore babies at the end of the day. The reason they did this is because of several fold. One is because the laboratory conditions were so poor.
Okay.
To the extent that you need to put multiple embryos on the hope that one or more might stick.
Okay.
The other reason is that because sometimes patients' conditions dictate that in terms of them getting older, and we can talk about that in a little bit.
Sure.
And because genetics is affected by aging, female aging in particular, they used to put multiple embryos. The problem when you do this is you end up at the end of the day with multiple pregnancies. Multiple pregnancies for us in medicine is, and in our field in particular, in reproductive medicine, is a complication. So therefore, because of that, you have early deliveries, more hypertension, more diabetes during pregnancy. And even when the babies are born, there's more risk of operative deliveries for the patient herself. And more significantly, there's higher risk of infant mortality and cerebral palsy. Almost 4 times more infant mortality and almost 10 times more in terms of cerebral palsy, all related to prematurity. So therefore, the technology has morphed into choosing an embryo, making sure the embryo is genetically normal, and therefore obviating the need to put multiple embryos, and get a higher pregnancy rate, and at the same time minimize multiple pregnancy rate.
What we're going to do is we're going to take a short break, and then we'll be right back, and we're going to talk more about the genetic aspect of it. Please stay tuned. Welcome back, and thank you for listening. We are talking to Dr. Shamma about, before we went on break, we were talking about the genetic aspect of infertility. And, you mentioned to me that we're better at it now. And, isolating one or two, and you said one.
One.
Okay.
One.
Yeah, okay. Is that correct?
It is absolutely correct. But let's before tell you why genetics is important.
Okay.
Two things, Khalil, happen as women get older.
Okay.
Number one, the repertoire of eggs that they have diminishes as they get older, to the extent that they start with around 400,000 eggs at puberty. At the age of 37, they're down to 25,000 eggs left in their ovaries. And then at menopause, they have zero. So the older the woman is, the less number of eggs that we can actually potentially utilize to do whatever it is that we need to do in assisted reproduction. So that's the first concept. And that's clearly just related to deterioration in the ovaries, and therefore diminishing of the number of eggs that are there. The second thing that happens is the genetics of the eggs that remain becomes compromised. And again, let's put that in perspective. If you have a 30-year-old woman, half of her eggs are genetically already screwed up. If you are 35 years of age, 45% of her eggs are only normal, and therefore 55% are genetically abnormal. Yeah. At 40 years of age, it's 70 to 75% are genetically abnormal, and only 20 to 25% are normal. And it gets to become even more of a concern at 42 and older, where 85 to 90% of the eggs are genetically of a concern. So therefore, allowing us to do genetics on the embryos, and we can talk about the other part of my story, allows us to determine which of the embryos that exist in the laboratory are genetically normal to the best of our human ability, and then put one back, and therefore avoid putting multiple pregnancies, avoid resulting in multiple pregnancies. So the reason we are able to do this is, again, the technology to determine the genetics of the baby has actually developed over time, and that's one of the things that has been developing ever from the past, maybe 10, 15 years ago, has been developing to let us to this stage where we can actually have a technology potent enough to be able to allow us to determine this on just 5 cells out of 300 cells of that embryo. So the way we do it, we take a day 5 or 6 embryo, we do genetic analysis on those 5 cells using a technology called high resolution next generation sequencing. And that technology allows us, Khalil, to be able to determine on those 5 cells if they are normal or not, and extrapolate to the rest of the embryo its genetic potential, and therefore choose the one that are normal. Prior technologies were not as robust, and therefore not as
specific,
not as sensitive on one hand, and not as specific on the other hand.
Exactly.
So that's why we basically have currently, at least in IVF Michigan, we have a success rate of literally close to 76% with just putting one embryo that is genetically normal at the end of the day.
Is that something this year happened, or you've been working on it?
Well, it has been increasing to the extent that now with one embryo we can get 76% of the patients pregnant and deliver. I mean, that's like an amazing feat.
Okay.
To some degree, the technology cannot allow us to get to better than 80% from a technological standpoint because of something called mosaicism. But at the end of the day, 76% is very close to 80%, and that's why we're very proud of it.
Sure.
And we clearly published data. This is one of the accomplishments this year. We published a major paper in our Fertility and Sterility, which is actually the most prestigious journal that we have in the US, where we proved for the first time ever in a randomized way that when women are between 35 and 40, it is better to do genetics on the embryos than not do genetics on the embryos, and choose one embryo, get a high pregnancy rate, and yet minimize the concerns related to multiple pregnancy and preterm delivery.
Sure. For listeners who are not really familiar with the process, you get your patients and they come to you, they've tried for several years, they can't, conceive. You're talking about, is it you're harvesting the embryo from the woman's body, adding the, how does the whole thing works? Just give them an idea, like a rough idea,
sort of
without
a bird's eye view of the whole process.
Exactly.
Women come to us having seen OBGYNs in Michigan or in Ohio or they come to us actually sometimes from different states and different countries.
Sure.
But they come having had a basic workup usually. We rarely do the basic workup ourselves because they would have seen their primary care physician or their gynecologist for that. So they come to us with an issue, either male-related concerns, ovulatory concern, tubal concerns, and they might have tried a little bit of technologies available, oral medications and or vitamins and so on. So they come to us seeking care at the maybe higher subspecialty related level. So we offer that. And in the context of in vitro, what we do is we give medications to women to produce a multitude of eggs, usually 10, 15 eggs if we can. Take those eggs out, take the sperm, microsurgically fertilize those eggs, make them embryos, and then usually, if they don't want to do genetics, put 1 or 2 embryos back somewhere around 5 days later. Or if they were willing to do genetics on the embryos, take those embryos, do microsurgery on the part of the embryo that's going to become the placenta, the afterbirth, take 5 cells out, do genetic analysis on those embryos and freeze it, and then 4 weeks later put, at the earliest, a single embryo back that is genetically normal. So this is in general how it is done, and this whole process is around 6 to 10 weeks. 6 weeks if we do not do genetics with the embryos, and 10 weeks if the embryos end up being replaced in the context of genetics.
What's the frame of time, like how many visits?
If they don't do
Roughly.
Genetics, it's around 5 visits. If they do genetics, around 8 or 9 visits total.
Okay.
And the visits are short visits. The surgery itself to take the eggs out, for some of us, I mean, I've done like over 25,000 of them, is literally around 6 minutes.
Okay.
The major work for us is in the laboratory.
Okay.
And then putting the embryo back is sort of an innocuous procedure, but it is highly technically, delicate procedure.
Sure.
And that usually takes less than a minute or two.
Are these like a little needles you use?
Yeah, I mean, to get to the eggs out, we have to use ultrasound-related technology and ultrasound-guided related procedures to allow us to retrieve the eggs through the vagina, going through the pelvis, through the ovaries, and then that's how we usually get the eggs. And at the same time, making sure that we avoid other organs that are significant in those areas.
Sure. Now we were talking, and you said there's another side of the genetics issue. What is this?
Here, genetics is important because, as we said, it relates to aging. But also genetics is paramount as it relates to pregnancy loss. Put it in perspective. Around 50 to 60% at the least, and maybe up to 75 to 80% of all losses happen because of a genetic concern in the embryo. If this happens once, it could be because of chance, because of women sometimes do lose pregnancies because of genetic issues in the way the embryo is developing. If this becomes a recurrent theme, that is, you have 2 losses or 3 losses, and especially at a younger age, this occurs at the chance of around 1-2% of the population. Therefore, it cannot be because of chance. And oftentimes, it's because of genetics. So the value of the technology that we offer is that it allows us, in those instances, in those couples that have recurrent genetic losses, to make them have embryos, choose the embryos that are genetically normal, and only put 1 embryo that is genetically normal at the end of the day. Again, maximizing pregnancy and almost eliminating pregnancy losses. Because as we said, most pregnancy losses happen because of a genetic concern related to the embryos.
Is there a specific group of the population, for example, people of Middle Eastern origin, people of European origin, are more prone to genetic issues?
Yes and no.
Okay.
So generally, somewhere around anywhere between, we used to think 2 to 5% of patients with recurrent losses have issues in the parents, and we actually today saw 2 of them as an example, where somebody has a part of their chromosome broken, attached to another part, or some part of it is broken and inverted and so on. Those situations we used to think they used to happen around 5% or so of patients with recurrent pregnancy loss. But then it turns out, based on new work that came out this year, maybe up to 15% of them, of those couples, will have genetic issues, which could be avoided if we do genetic analysis of the embryos.
From the beginning, yeah?
That is correct.
Yeah.
In our Middle Eastern population that we see in Michigan and elsewhere in the Arab world, more so actually in the Arab world, there is another part of the genetic story that is absolutely relevant. And that has to do with recessive disorders. Recessive disorders, Khalil, are disorders that are genetic concerns that happen somewhere in 1 in every 27 couples in the US population. In the Middle Eastern population, we do not have any data on this, but we think it happens around 1 in 10. And what I'm trying to suggest is that if the 2 couples share a particular deadly gene, even though they themselves do not express the disease related to that gene, but because both of them carry that gene, a baby in 25% of the times, or 1 out of 4, will be affected with a particular genetic disorders that have lifelong effects on the baby itself and the adults when it grows. And the reason it is more common in the Middle Eastern population has to do with consanguinity, has to do with the fact that we tend in the Middle East to marry from cousins, second cousins, relatives, from, even doesn't have to be cousins, from the same area, the same tribe, the same geographic location. And that increases the incidence of those genetic recessive disorders. So to that end, what we actually offer currently, every single infertility patient, we offer what we call carrier screening. We offer screening for almost 10,000 genetic recessive mutations for the 2 couples to see if they're one of those 10 to 27 people that carry those things in common, and then create embryos that do not have those concerns by checking the embryo for that particular genetic disorder that they might or might not have.
Okay. What we're going to do is we're going to take another break, and we'll be right back. Please stay tuned. Welcome back, and thank you for listening. We are talking with Dr. Shamma about infertility, and we left it off when we're talking about the importance of genetics. Now, Dr. Shamma, is there a treatment for that? And what is the treatment?
Well, I mean, the treatment of infertility has to do with the cause of infertility.
Okay.
We divide causes, Khalil, into two categories. And then there is a third category, which is, we call it unexplained, which we can address later on.
Sure.
But oftentimes the causes have to do either with female-related factors and or male-related factors. Somewhere they're equally balanced in terms of half of the situations are female-related and another half are male-related. In the Middle East, with our patient population being the way it is, with less sexually transmitted diseases and so on in our community, male factor concerns are more of an issue than female related concerns. That is being actually offset in our population here in the United States because of another factor that affecting women, which has nothing to do with STDs, sexually transmitted disease, but has to do with obesity. More and more women in the United States becoming overweight and or obese, and that certainly affects their ovulatory patterns and therefore becomes more of a concern in those instances. But male factor infertility has remained a major at least 50% of the situations that we deal with. And therefore the treatment depends on the concern. So I'll give you an example. If a patient comes to me, young woman, that has irregular cycles because of lack of ovulation, the treatment doesn't have to involve an assisted reproduction. We can just make her ovulatory. We can recommend weight loss. We can recommend drugs to improve ovulatory pattern. And with all of that, there is a fairly good chance at least 50% of them at the end of the day achieve a pregnancy just with oral medications. They don't have to do in vitro. Now, a lot of those medications have side effects as in terms of multiple pregnancy related concerns, but then that's the only way to do that is to use those medicines, otherwise they don't ovulate. Now, if the issue is related to tubal disease, that is the tubes are blocked, damaged, surgically absent, whatever, then the treatment has to involve in vitro fertilization to avoid the problem of getting the embryo into the uterus. Because if the embryo cannot get to the uterus because the tubes are damaged, you have to bypass it. And that's in vitro was initially developed specifically in situations where there is tubal disease.
Are there any natural remedies for
tubal disease?
Yeah.
No.
Or any other step from this?
No remedies. In the past, we're talking about 30, 40 years ago, when I did my training 30 years ago, we used to do microsurgery to try to fix the tubes, make them look good, whatever. We found out that the success rate is so dismal that it doesn't justify the invasive procedures that were done in those instances, because you can bypass the tubes by doing in vitro and putting the embryo directly into the uterus and not to worry about the tubes. So we actually have shied away for many years, almost 15 years now, from doing microsurgery on the tubes or tubal surgery to try to make them look better. Because another side effect that happens when we used to do that is pregnancies happened in the tube.
Yeah.
I mean, we would put them in, we would fix the tubes, but then they're not really fixed properly. And then when people get pregnant, eventually you end up with a pregnancy in the tube, which is a major concern. Now, that is the tubal part of the story. The uterus is harder to fix. The uterus, if it's abnormal, whether it's because of tumors, polyps, fibroids, scarring, whatever, is a more complicated story. I mean, one of the surgeries I did today, I mean, my resident with me will attest to that, is somebody who had a huge fibroid growing out of her uterus, even coming out of the cervix into the vagina. So we had to do surgery for that to make the uterus hospitable enough so that an embryo can implant there at the end of the day. Lastly comes the issue about male factor. Now, male factor depends on the degree of male factor concerns. Sure. You could have mild male factor where you can just tell them, you can take some vitamins and see what happens, especially if the patient is young. But then there are situations where there is zero sperm.
What kind of vitamins in this case?
We recommend antioxidants. We recommend CoQ10. We recommend.
What's a CoQ10?
It's an energy booster.
Okay.
We recommend selenium. We recommend zinc. We recommend vitamin C. So all of those concoctions are present in multiple formulations in the market. Not to advertise any of them, but we prescribe them to hope that we increase the ability of that sperm to be viable, and therefore can help some patients with very, very mild forms of infertility.
So we need it to be there, and then we need it to be viable.
We need it to be not just there, we need it to be present in the amounts that are necessary.
Okay.
And to put this in perspective, listen to this. Each time us men deposit sperm in the vagina, we deposit around 100 million sperms. Imagine, 100 million sperms.
Wow.
If at the end of the day 10 to 40 sperms ever reach the egg, it's a miracle. From the 100 million, 10 to 40 sperms ever reach the egg. So if the sperm is compromised, you can imagine how very little, if any, ever reach the egg. Sometimes, knowing what I know, I wonder how people get pregnant. I mean, how I was able to produce kids in my own family or anybody. Because I know how difficult it is. And yet, thank God, 95% of humans are fertile. of men are fertile, and 90% of couples have babies. Thank God for that. Otherwise, I'll work day and night, and there won't be enough time to service all our and help all our patients. So the number has to be there. The motility of the sperm has to be there. That is, you have to have not just the numbers present, but the numbers have to equate to the sperm moving in the right direction to get to where the egg is. And finally, the shape of the sperm is basically the most critical factor. Unless the sperm is normal, it cannot penetrate the outer shell of the egg. We call it the zona pellucida in English. It cannot penetrate that shell and therefore fertilize the shell, the egg, and therefore become an embryo and therefore a baby at the end of the day.
Okay.
So unless all those parameters are there, then not much
it's not gonna
will happen.
Exactly.
Yeah.
Exactly. Yeah. And knowing at what stage it is, then you devise the treatment and so forth and so on.
To put it in, I mean, sometimes we saw few patients, actually almost 3 of them today, whereby the man has 0 sperm, but might have sperm in his testicles. So we go directly to the testes to get sperm out surgically.
How do you know that? What they may have in the testicles?
Well, sometimes we don't know.
Oh, okay.
And sometimes the surgery itself allows us to know
Okay.
that there is or there isn't sperm.
Okay. Okay.
And if there is sperm, take that sperm, whether it likes it or not, put it inside the egg and fertilize the egg, and that's the end of the story then.
Okay. Those, you're a passionate man, and sometimes those who don't succeed, and then you see the disappointment on their faces,
and they cry.
Yeah.
And it's emotionally burdensome to them, to put it mildly, but also for us. Even me, having been doing this for the past, since I've been a doctor since 1986, so 33 years, and in my subspecialty since 1990, 29 years. It is emotionally frustrating to us when they do not conceive.
Sure.
It's emotionally draining for them when it doesn't work. But then we tell them that there's always hope when there is hope. Sometimes I tell them there is no hope and it's time to stop. But when there is hope, our job is to show them where the hope is, and the hope to be realistic, offer them whatever is necessary to achieve the goal, which is at the end of the day, take home a baby that they can play with and eventually go to college.
Yeah. Can continue the family line and whatever.
Yeah, I mean, see, I always think of it this way. Having 6 kids, I mean, most of the time kids are a pain in the you know what.
Yeah.
Yes, but so 90% of the time they're a pain, but 10% they're utmost joy.
Absolutely.
So it is for that 10% that we have kids, I think. I don't think it has to do with lineage or it has to do with anything. It has to do with this 10% joy.
Paternal feeling is unbelievable. I remember when my son was born, Yusuf is my oldest, he's 13, and prior to that I didn't care for kids. And then all of a sudden, we decided to have a child, and we were successful and conceived and everything. And then when he was born, it's like somebody flipped the switch. It's just totally different paternal feeling. And it's just amazing.
I mean, for me, it was a little bit different because my first was born when I was 24 years old. So I was pretty young, almost clueless. But at the same time, I mean, I loved her from and by the way, I'm going to be like a grandfather come January, God willing, because she's due. But so the point that I'm saying is that some of us have that innate feeling of becoming dads early on, and I guess I accept that, and I see that. Yeah. So for women, it's actually more pronounced, that feeling. Yeah. I think the maternal instinct is so it's so important in their lives that actually it pushes a lot of women to seek care at an earlier stage than us men. And I understand that. And that is why there is something that I hope we have time to discuss today, which is the importance of egg freezing.
Okay.
Because that is a technology that is absolutely helpful in the context of delaying childbearing. And we can talk about that
let's talk about it briefly, and if we get a chance to talk about it later on, we can expand on that.
Sure.
So what's the importance of that?
So here's the thing. Remember we mentioned, Khalil, that as women get older, they age. Yeah. They age both in the number of eggs that remain and also in the genetics of the eggs that remain. So therefore, we actually tell I hope all our listeners hear this, that If by 33 a woman is not with child, which means she's not pregnant and ready to deliver, we strongly recommend that they should consider freezing their eggs. And the reason this is happening is because in the past, women at 24 used to have their first kid.
Sure.
Now they're 30 and not even thinking about it. And what happens is all of those things happen. The genetics become a concern, and the number of eggs become a concern, and therefore the ability to become parents might diminish as they get older. And the chances of them being absolutely sterile as they get older is compounded by the passage of time. So therefore, the ability to freeze the eggs is like an insurance policy that you pray you never use.
Okay.
It's like in life insurance.
Sure.
You have their eggs frozen, and if you want to get your MDs, PhDs, JDs, whatever thing that you want to achieve, you're free to do that. You have all those eggs in the freezer on hold till you are ready to have a family, or you find a suitable mate, partner to be able to procreate with.
Yeah. Is it expensive?
It is expensive because the technology is expensive, but if you put it in the context of going through life childless versus the $10,000 that or so it costs to freeze your eggs, well, I'll take the $10,000 and invest them for the longer term in terms of keeping somebody's ability to have a family.
Is there a way we can tell who's like this woman is gonna have tremendous amount of eggs, this woman not as many eggs, so she should freeze her eggs?
See, the genetics is true regardless of how many eggs you have or you don't have.
Okay.
It's all related to age. And those numbers are consistent across populations, across the whole human race. What is different is how many eggs you have left behind.
Okay.
Those vary from one person to the other, but averages do exist. But there are blood tests that we can do to determine if somebody has a biological clock that has time left on it, or that the time is becoming extremely relevant for those people by doing a very simple blood test in that regard. And again, just today, I mean, we saw so many people that have diminished ovarian reserve testing, and yet they are only 36 years of age.
Sure.
And to give you an example, I mean, we saw somebody who's young, was in a good relationship, has a kid, and yet at the end of the day, waited few more years to have another child, 6 years, and then by then the ovarian reserve became significantly low, whereby she cannot use her own eggs, and now is currently using donor eggs, potentially. The issues that exist in our population related to aging are all offset by using third-party reproduction, by using eggs from somebody else. I think it is less acceptable in our community than other communities because of religious, ethical reasons, whatever, but a lot of people in our population use it.
Sure.
The part that is really still more or less not common in our population is what we call gestational surrogacy. I don't know if we've never talked about that.
No, we've never talked. Before we do that, let us take a short break and we'll talk about it immediately after the break.
Right.
Stay tuned, please. Welcome back and thank you for listening. We are talking to Dr. Shamma about infertility, and then we left off at, please help me.
Third-party reproduction.
Exactly.
So let me explain to you what third-party reproduction. Third-party reproduction involves taking eggs from somebody else and or sperm from somebody else when the situation is dire, Khalil, when there is no more sperm or there are no more eggs. So when in those two conditions, you can always get eggs from somebody who's substantially younger or sperm from somebody who does have sperm and use it in the context of raising a family with a particular couple. The one thing that we have not addressed before is the issue of what we call gestational surrogacy. The sperm exists, the egg exists, but let's suppose uterus doesn't exist. It doesn't exist because of surgery, it doesn't exist because of fibroids, it doesn't exist because of scarring inside the uterus, it doesn't exist because you were born without a uterus. There is a condition, a couple of conditions in medicine whereby a uterus and the upper vagina doesn't exist. and it has a long name in medicine that I'm not going to share it on the air, but it's called Mullerian agenesis in a very simple way.
Sure.
In those instances, you need a uterus to gestate a baby. To that end, what we actually have created in another subsidiary, firm, a company that we have called the Gift of Life Surrogacy Agency, we have actually created an agency that gets people to offer their services to carry a pregnancy for a particular couple. And we've had many couples from our Middle Eastern community that have utilized those services. And it's actually the only surrogacy agency that exists in the state of Ohio, actually.
Ohio.
It's not legal to do it in Michigan in the sense of the gestational carriers being able to be compensated in Michigan, because there's a statute against it. But in Ohio, it's completely legal.
They get paid to do that.
Yeah, they get paid, and we actually, our job in the agency is to take the women, this is my phone, is to take the women, screen them, and make sure that they don't have any social issues, emotional issues, forensic related issues, medical concerns, sexually transmitted related diseases, and so on. We monitor all of those. And then at the end of the day, if they're suitable,
good environment.
Good environments, if they're suitable, match them with intended parents. And our job in the agency, the Gift of Life Surrogacy Agency, is to chaperone them from the beginning to the end during that process.
Does that play any role of the genetic of the person who's carrying the egg? I mean, you have the sperm from this person, the egg from this person, and there's this person just gonna, you put it there. Her genetics, does it have to play any role?
No, it doesn't. It doesn't. I mean, it's a gestating uterus at the end of the day. And the heavens created humans in such a way whereby the uterus carries always a foreign entity. Because remember, half of the genes of that baby are foreign. They're from the father. So the uterus is very tolerant, to use that word, to an embryo that is, or a baby that is foreign genetically, and because otherwise you reject the baby. And pregnancy is such a immunologically tolerant state that it allows us to take an embryo that is not 50% foreign, 100% foreign, and put it in another uterus, and that uterus will allow it to develop as normally as anybody. And
throughout the 9 months.
Through the 9 months.
Yeah.
So the job for us is to create the environment whereby we match the intended parents with the gestation carrier, but also match the age of the embryo, eventually from a medical perspective at IVF Michigan, with a uterus that has been prepared medically to allow that implantation to take place.
What kind of relationships they have? Do they really know each other?
They have to know each other.
They have to know each other.
Because at the end of the day, they're giving the baby back to the intended parents.
Sure.
And it would have been, God forbid, disastrous if they do not give it back to the intended parents. And it's contractually agreed on between the parties, between the intended parents and the gestational carrier. And I have to say something. I strongly believe that those women, the gestational carriers themselves, are giving the utmost gift to the intended parents. That's why actually when I was asked, what do you want to call the agency that we created years ago? I said the Gift of Life Surrogacy, because in my opinion, it's the ultimate gift that you can give somebody else. Yes, it's an expensive gift, but at the end of the day, it's the ultimate gift, because 9 months is not like a walk in the park.
Exactly.
It's 9 months of sleeping, waking up, and eating, and tolerating,
body
changing, and everything.
What's the physical and emotional, the emotional attachment of this person who's carrying the child after the birth?
I'll tell you, half of our gestational carriers remain in contact with the agreement, of course, and with the acceptance of the intended parents with the baby. So they remain in their lives for a long time. They're invited to birthdays. the intended parents send them pictures. I mean, we just saw somebody today that came in, and she said that she has developed this beautiful relationship with her gestational carrier, where she gets invited to stay at their house so often, every once in a while, and see the baby growing up because she helped bring it to life. I mean, this is a most beautiful thing.
Are there like a counseling for the...
Oh, you have no idea the amount of, whether it's emotional counseling, psychological counseling, social, financial, I mean, all of it has to be addressed on the front end. Otherwise, you have issues.
Exactly. Has it gone wrong?
Everything is possible, correct? I mean, we've had situations in Michigan whereby a couple did not do, I mean, the gestational carrier refused to give the child back, and a judge in the western part of Michigan gave it to the gestational carrier, but knowing in that instance the intended parents had no relationship because they used donor egg, donor sperm, so they had no genetic connection to the baby. Eventually they do use the different gestational carrier, and they have a baby now with us, but again, that baby had to be given because it was conceived in Michigan, and because the judge over there in Grand Rapids decided that it was against public policy in Michigan to give it to the intended parents, and gave it to the gestation carrier. But that tends not to happen in contractually agreed upon situations when it is done in a proper way with legal counsel and so on.
It is really a huge gift of life for those who need it the most.
Yeah, I think so.
And if they understand the process and the consequences and all of that, it's just incredible. Can you freeze sperm?
You can freeze it forever.
Okay.
We can freeze eggs forever.
Okay.
I mean,
is it as costly as freezing eggs?
No, us men, because we can produce it ad lib.
Okay.
Anytime we want, in essence.
Yeah.
So it costs much less. I mean, to freeze sperm, and we offer it to people, let's say, undergoing chemotherapy or radiation or surgery before they get any of those treatments, to make sure that they have sperm cryopreserved later on in life. It costs somewhere around $60 to $100 to do this, and then maybe $200-300 a year. Compared to freezing eggs is a much more complicated story because of the surgery involved and the technology involved to do it.
And then they have to be screened as well.
It's interesting. They don't have to be screened if they're going to use them themselves. Again, to put this in perspective, all of what we do is governed by the Food and Drug Administration. So there is a law in the U.S. Congress, regulation called whatever CFR 1271, and that regulation governs what we do, but it only applies if we use germ cells, eggs and or sperm in the context of somebody else, because the FDA is not concerned about if you're going to transmit a disease to yourself. Correct? I mean,
sure.
But they're concerned about you transmitting the disease to somebody else.
Somebody else, yeah. Okay. Earlier we were talking, and you said something about unexplained infertility. What are we talking about here?
Yeah, unexplained infertility. I think I hate that term, but if you look at it in population studies and so on, almost up to 25% of situations, it is, Khalil, unexplained. And I will always tell my residents, people that I'm training, unexplained means that we, the doctors, the subspecialists, did not get to know what the reason is. It's not that there is no reason, but we don't know what the reason is. Almost always it's one of two things. Either there is undiagnosed male factor infertility, and that affects sperm-egg interaction and therefore fertilization and therefore pregnancy, or there is an issue with the tubes being able to pick up eggs from the ovaries, and therefore the ability of the tubes becomes compromised, and therefore the embryo never makes it to the uterus. That is the power of in vitro fertilization, because those two parts are overcome when we do in vitro. When we do IVF, whether the sperm likes it or not, it's fertilizing the eggs. And whether the embryo likes it or not, we're putting it into the uterus bypassing the tubes. So the unexplained situation becomes mitigated if one does in vitro at the end of the day.
In the old days, women used to have all of these tales about, drink this and drink that and you'll get pregnant, and some used to do, and it seems like she was going to get pregnant anyway, and I'm not sure how much the psychological aspect had to do with that.
Well, I mean, again, to put it in perspective, food is important.
Yes.
Because we need to live. But then overeating is also a problem, and exercising less is a concern. So eating healthy diets, and our Mediterranean diet, by the way, our Middle Eastern, the Lebanese diet, you and me, is like the best diet. So with that, putting it in perspective, it has been shown in studies that the Mediterranean diet is the best fertility diets. But obesity itself is extremely relevant in terms of fertility, whether it's for men and for women. For women, it causes ovulatory dysfunction because it raises their insulin and makes them not ovulate. Also, all of the concerns related to pregnancy are become worse when you're obese. More hypertension, more diabetes, all of it. More issues related to surgical concerns if you have a C-section or whatnot. For men, it diminishes sperm counts because your estrogen becomes more prevalent because if you are obese, and therefore the less obese you are, the more fit you are as far as the man is concerned, the better the sperm count and the better the ability to be fertile.
Time of the month, does it really matter?
Sure. I mean, the egg only lasts 12 to 24 hours. So if you have sex all other 29 days and not the day when it is supposed to happen, it's not. I'm joking to some degree because sperm does last 3 to 4 days sometimes. So the best time that I advise patients to have intercourse is in the first 6 days before ovulation, 6 to 7 days tops. And if they have, make love every 36 to 48 hours, that suffices usually. At the end of the day, you need to have sperm at the time when the egg is there, because the egg itself only lasts 12 to 24 hours. So you have to have the sperm there in the system, ready for that egg to be there so that the egg gets fertilized and then become an embryo.
And we did talk about this before, but I'd like to mention it again, is environmental, the habits that we have and the life that we live and all of that either can contribute to success or failure.
Well, I mean, the bad habits contribute to failure. The good habits can contribute to disaster. I mean, I'm joking. So good habits are always good. Bad habits are always bad. So smoking is bad. And especially in our Middle Eastern community, smoking this argile thing or shisha, whatever it is that they call it, is horrible. Because it absolutely diminishes the ability and the potency of fertility, and therefore sperm counts diminish and all of it. Alcohol is bad. Drugs are bad. We're talking illicit drugs, whether it's cocaine, whether it's heroin, and unfortunately, even in our community, those things are becoming prevalent and ought to be discussed. So all of those are major concerns, Khalil, and people need to make sure that they have healthy lifestyle. They have to avoid being overweight. They have to exercise more. They have to eat healthy, avoid smoking, avoid drugs that are illicit, and make sure they love their wives.
That helps. On this note, we're going to take a short break. We'll be right back. Welcome back, and thank you for listening. We're talking to Dr. Shamma about infertility, and we're kind of wrapping up about some of the segments we've had over the the entire year, and we only have 2 minutes, Doctor. So quickly, is there anything we haven't mentioned that's really important to mention?
I mean, we underscored several facts.
Sure.
Number one, I want to make sure that all our listeners have a very happy new year and happy holidays and all of that.
Same to you, absolutely.
Second is infertility is not a taboo. Infertility is a problem that affects 10-15% of people in the population. Third is that most people are fertile, don't have to worry about it. They just need to enjoy having their partners around and have babies. But we tailor to the 10-15% that cannot achieve pregnancy, and I just want to emphasize to them that the services do exist to, God willing, make 95% of those end up with their goal of achieving a pregnancy and having a baby at the end of the day. And that the technology now has morphed to a degree that allows us to mitigate any of the concerns related to the technology, because we are now limiting pregnancy to a single baby that delivers at term, that is healthy, without having any of the losses that used to happen in the past,
Sure.
and any of the genetic concerns that used to sometimes be present when babies are born.
Absolutely. And I also want to mention the fact that now this year, or you've been working on it for a while, this year more so, that you're using the one embryo.
Almost 65 to 70%, Khalil, of every single patient that we do assisted reproduction on, almost 65 to 70% of them are now putting a single embryo, getting a pregnancy rate that is, as we mentioned, around 76%, and yet there's no need to put two embryos.
Sure. I really want to thank you. It's been an honor and pleasure to talk to you, as always.
Honor is mine.
And, just everybody be healthy, have fun, and make babies. And if it doesn't work, come see Dr. Shamma. So I want to thank you so much for listening. I want to thank you for your time, doctor. And I want to thank everybody for the production team. Have a wonderful and safe holidays. Thank you.
You're welcome.